We're here today at the 50th annual meeting of the Society of Thoracic Surgeons, a special anniversary meeting celebrating the rich history of this organization. And I've been joined here by a panel of experts in the field of atrial fibrillation, all thought leaders, to discuss the treatment of atrial fibrillation today. I'm Jimmy Edgerton from Dallas, Texas, and I'm joined on my right.
I'm Richard Sheeman from UCLA in Los Angeles.
Vinay Badwar from the University of Pittsburgh.
And I'm Jonathan Philpott from Norfolk, Virginia.
Thank you, gentlemen, for joining us today. You know, the vast majority of atrial fibrillation that's treated by the surgical population today is concomitant to another cardiac procedure. And we have a group of patients who meet the criteria to have a maze done during that procedure. But just what is our penetrance like, Vinay, to doing that procedure when those patients come to the operating room? How many of them are actually getting the operation?
Well, I think our main problem is that we have now of all elective cardiac surgery being done, the last biopsy of the Society of Thoracic Surgeons database, the rich database that we have, I think there's over 152,000 patients that were elective cases, of which 11% had atrial fibrillation. The penetrance is roughly about 40% that actually got a surgical ablative procedure, around 62,000 patients. Of those, though the highest percentage that got ablated, actually we've improved over the years, is that in that last 2005 to 2010 analysis, about 62% that had a mitral operation, an isolated mitral operation, actually got ablated. However, we're less aggressive in patients that had isolated aortic valve procedures or isolated CABG procedures, somewhere between 38 and 27% respectively in those cases.
And I can understand that, because if you're doing a coronary artery bypass graft on a sick patient who also has atrial fibrillation, it's extra effort to open the atrium and go inside to do this procedure. But have we really done the patient a disservice if we're leaving out a maze? They've had atrial fibrillation for years, and we're going to have to stop and open the atrium to do that? Tell me about that, Dr. Sheeman. Have we really done the patient a disservice if we leave that out?
Well, I think, first of all, we need to make sure that our community of cardiac surgeons are familiar with the technologies to make this operation much easier than it's been in the past. Because if you have the toolkit and the skill set, you'll be able to do this operation safely, even in that group of sick patients. I do believe there is a natural reticence when you're not working within the left atrium to add that extra complexity to the operation. And I think that requires a careful assessment by the surgeon of the risk factors of the patients in atrial fibrillation. But since we know atrial fibrillation causes strokes, other morbidities, and even possibly premature death, I think when that's described to the patient and the surgeon feels confident that adding a maze does not really increase the mortality or morbidity of the operation, only a little bit extra time, then the operation should be done.
I'd echo that. That's been our experience as well. You know, when I came through and when we started running up with this, there was always that hesitancy to go ahead and add the procedure, but it's just practice. And the data is very clear. If you leave this operation out, you are doing your patient a pretty dramatic disservice. We've seen multiple readmissions. They come back with stroke, heart failure. There's definitely the association of possibly death as well. It's definitely a disservice if you leave it out. Getting more familiar with the operation was key to us, and that also convinces us that it is just as safe. The procedure becomes very routine. Adding it in really adds probably 2 pleat shots, so probably about 30 to 40 minutes. And once you get the practice with it, it tends to become something that you're just much more familiar with.
I think that's critical to understand, because there are a number of publications that showed that if you leave the maze out of patients who are candidates for it, compared to the patients that have had it, over the ensuing 5 years, the rate of stroke is 5 times the group that didn't get it. The rate of heart failure is at least 3 times the rate of the group that had that. Vinay, you agree with all that?
Absolutely. We looked at the STS database on isolated mitral surgery and linked the existing STS database to the Centers for Medicaid Medicare Services database in our paper a couple of years ago, and looked at multiple thousand patients, 14,000 patients, and one of the largest drivers that, aside from renal failure, et cetera, that are not controllable, largest factors that were responsible for readmission rates was indeed atrial fibrillation.
And I've got a question about that. It's fascinating to me that we got so focused in with memory use, appropriately so, and we used our data tracking memories. I think most people out there use, dashboards and red light, green lights to track this and our mortalities. And we've really cleaned that up. We do a beautiful job with memory use across the country, and yet we're at 40% at the last biopsy. To me, that's egregious. I can't believe that we're that low. As a society, we've got to get that up. And we've talked about this a little bit. What should that mark be? And I'd be kind of interested to hear what you guys think it should be. I think at a minimum, for the first couple of years, it'd be great to be 80%. Honestly, truthfully, I think it should be 90%, at least in our hands. What would you guys say?
Well, I think our first goal should be in mitral valve surgery, because there's really no excuse not to go ahead and perform at least a left-sided complete maze lesion set. I do think there probably is a subset of patients where it's not worth it. Giant left atrium, you got to know when not to do this. But I think the cardiology community probably has a rising expectation, since they refer so many patients for catheter-based ablations with all the problems that that procedure has. Then I think there's a very high expectation that cardiac surgeons will appropriately perform concomitant maze, particularly in the mitral valve population. When you get to the aortic valve population and the coronary bypass population, that's where the surgeon's comfort level to go ahead and add the maze procedure without increasing any morbidity or mortality to the patient will be very, very important to get that bar as high as we think it should be.
Yeah, I think it's incumbent upon us as a society to provide our members and colleagues around the world the comfort to know that the literature supports adding a maze procedure. But of course, it's training, it's experience, and
it's knowing that you need to change your technique. Mm-hmm. And the biggest thing that we need from the society in terms of knowing how to change your technique are your results. That's been the singular most important thing that we had in Norfolk. Almost all of our patients were enrolled in a trial, so we got that feedback back to us. And when you start to see that your results are below par, it encourages you to go out and say, maybe I'm not doing this exactly the way I should be. It encourages every surgeon to go and find out what they need to do to improve their technique. So it's kind of, for me, it's a two-part thing. Number one, you got to do it. But number two is you got to know that what you did worked. How are we going to improve that? It's, I think at our last check, we've only got, is it true that there are only 13 sites are participating in the Afib module right now?
So
that's a potential area for us to really lead and improve.
Let me comment on that, because luckily we now have been able to get the Society of Thoracic Surgeons in their last update to take the module and actually make it part of the database. We've had to simplify it to some degree for practical reasons. So now the data is being captured as a routine instead of looking for a special participation in a module. Number two, maybe the next step is to go ahead and give the feedback to every participant. What is your concomitant maze rate compared to the STS average and compared to other institutions? And that may give annual feedback to every single participating group and help to move that bar to the goals that we need.
Yeah, that would be gigantic for me, because surgeons they're funny creatures, and if they see they're not scoring an A, they go back and they typically find out what they can do to make it better. But how are we going to capture the one-year data on that? That's the key.
Historically, Jonathan, what you said is true. Surgeons rise to the occasion to take the best care of their patients. We've done it with the institution of internal mammary use. We've done it with mitral valve repair. What's a little different about atrial fibrillation is to know your results, you have to follow the patient at least a year. You have to make a little bit of a step out of being a proceduralist into a disease management individual. And to do that, you're going to have to look at your one-year results. And surgeons should not be hesitant to say to their cardiology colleagues, I'm going to follow my patients for 2 years. They're coming back to my clinic so I know what my results are, because I have to know that, and I have a great tool in the STS database to document that.
I think outcomes of the procedure are critical, but when we look at penetrance and actually performance of the
Don't know your outcome until a year.
exactly, but the database is limited in that capacity at this point in time. But there's no doubt that every surgeon should accept the responsibility that if you perform an operation, you need to know what the outcome is. But on the other hand, just by giving feedback of whether you're performing the operation or not, we don't need one-year follow-up. That type of information can be incorporated in a new analysis that could be routinely done with probably minimal cost.
And it's okay to teach yourself in stages. Begin with your mitral patients. You're not adding much there. They're open. You just have to add the technique, gain your comfort level, and move on. And that might bring up the question of what lesion set do we do for patients? And Vinay, this is tied a little bit to the definition of AFib for each individual patient.
Correct.
Would you comment on that?
Well, I think one of our issues is to provide guidance to our colleagues, and right now there's a lot of hodgepodgery of the of interpretation of what's the definition of paroxysmal. I think non-paroxysmal versus paroxysmal atrial fibrillation is kind of the accepted approach now to analyses in atrial fibrillation, and the everyday scenario when someone comes and then the medical record says paroxysmal, but in truth, if you actually do the history yourself or ask, the patient's had a catheter-based ablation, the patient's had this prescription of a class 3 antiarrhythmic. In fact, that's probably not paroxysmal. And I think that's the kind of cases you do a disservice by not doing a surgical ablation procedure. So really doing a deep dive in the definitions when you see a patient becomes very important in case selection, and hopefully working together as a society to provide guidelines and updated guidelines on that would be important.
And to speak to that momentarily, there's a quick and easy way to repair any cognitive deficit that you may have. There's a 2012 consensus statement that both Dr. Sheeman and I shared authorship of that, and it is the most complete, practical statement there is. If you just take a few minutes to read that statement, you're going to know more about AFib than 90% of the people in your hospital. Speaking of that, when is it okay to do, I get asked this frequently, do I have to do the right-sided lesions? When is it okay to do the right-sided lesions? I was in a course once and a fellow asked me that. I tried to go through this erudite explanation. He said, let me just stop you there. I always try to go through all that thinking, but I could have had the right side done by the time I finished that thinking. Am I okay doing that, gentlemen?
Well, I think in general, if you are in continuous atrial fibrillation, the more you do, the better the result is going to be. Obviously, if you're through a full sternotomy and you have that type of patient, I think you ought to go for the cure. And the best way we can do the cure is to do what's called the Cox-Maze-4 procedure, which would be a biatrial full lesion set. The right-sided lesion set has been simplified. It can be done on bypass or so even off bypass, and it certainly doesn't have to be done during the cross-clamp time. And I think when people realize how to choreograph the operation for efficiency, they will find that adding the right side really adds a minimal amount of effort and will improve their results.
Vinay, let me ask you this. Is it okay if you're using the enabling technology of these energy sources, if you have a radiofrequency device open, it gets just about right up to the annulus? Is that okay?
Well, I think echoing Dr. Sheeman's comments, whatever the enabling technology is, we have to focus on a complete lesion set, a complete Cox-Maze-4 lesion set. Some enabling technologies allow the complete lesion set, some do not, which is where your question was.
Yes.
And so, without getting into specifics of device-related aspects, we have to complete the lesion set, which includes annular involvement, includes coronary sinus involvement, and those are the details of the nuances of the operation. But the general overall concept is don't cut corners, I think, is what the theme of this last bit of conversation is, and I completely wholeheartedly agree with that.
Yeah, I'd echo that too.
In Norfolk, we definitely think that adding the right side is the way to go. The procedure was designed as a complete procedure, and to me, it's like building an airplane, and you start leaving things off. It's like leaving a wing off. And I've spoken with Dr. Cox about this directly, and he gets upset when he hears about the right side being left off on purpose. I mean, those lines were there for a reason. And our Dr. Sheeman's comments about going for the win, I think, are very appropriate. It doesn't take long. I mean, you usually do the right side second. The patient's resuscitating at that point on bypass, and with practice, it usually takes us about 5 to 10 minutes to do it, so it's not long.
To just give a number, roughly, doing the right-sided lesions adds a 15 to 20% efficacy to the procedure that you're doing. And which of us would do a procedure with 80% efficacy when we could have 95%? And they may look confusing at first. It's basically 2 lesions. It's a looped over to the annulus and an inverted T. What order do you do these things in, Jonathan? How do you do this efficiently? What do you do on the pump? What do you do off the pump? On clamp, off clamp? What's a good approach for the surgeon to begin?
Every patient is different, and one of the things that's helped me tremendously is I sit down before the operation and actually plan out each step of it and how the maze elements are going to fall or choreograph the most efficiently into the procedure. Now, having said that, the tricuspid and mitral valves do generally kind of give you some hard points to steer by, because you do have to anchor the flutter lines onto the mitral valve annulus and the tricuspid valve annulus for those lines to be effective. And that's critically important, because that means that has to come before you put your valve ring or a replacement over the annulus, which would block it, which is a mistake. So you always want to do the maze before you anchor either an annuloplasty ring or replace a valve. If you get those mixed up, it's going to be very difficult to hit that anchor. In other words, to get that electrical dam to seal onto the annulus, and that can set up a perfect substrate for flutter, where you have something going around the annulus itself, and it's blocked by the ring, the sewing ring of whatever you put in. So for us, we typically cannulate the patient. Most of the time, I'll go ahead and do the right pulmonary vein isolation first, on pump. I almost do all of this on pump. And then we arrest the heart, do the majority of the left-sided ablations, and then follow with the coronaries. And then it'd be interesting to hear how everybody kind of goes to this, because there's no right answer. It's just the way that we typically do it. But then if the mitral needs to be done, we do a mitral, and then after that, we go ahead and do the tricuspid, and then finally we do our proximals. But
How does it alter your procedure if you're doing a right coronary graft or not doing a right coronary graft?
Well, the right coronary graft can be a little tricky if you're doing a single cross clamp technique, and the reason for that is you've got to open the atrium to do part of the right side of the maze. So measuring the graft sometimes can cause some anxiety, and particularly learning surgeons. The thing that's helped us is to go ahead and do the right distal first, and then measure that graft over to where it's going to be on the aorta and mark it. And get all that done with the heart distended as you'd like to make the graft measurement accurate before you go ahead and open the right side.
Vinay, Jonathan mentioned the importance of anchoring each lesion to an annulus, and each maze lesion is anchored to the central fibrous body of the heart, which is non-conductive tissue. And he spoke a little bit about the order of doing things when you have to place a ring. Tell me about guidelines and rings in the tricuspid valve.
Well, that's actually a very important, and I think our European colleagues are to be credited for really helping us with this, to provide some guidelines on this based on some of their literature. And that I think the issue that we have is that we see a lot of patients that have concomitant, the classic situation is those that present with mitral disease that also have concomitant atrial fibrillation. And we sometimes ignore the tricuspid annular dimension. And in fact, we shouldn't. And patients that have some degree of tricuspid regurgitation, and perhaps even a little bit more controversial, even those that do not, but have a very enlarged tricuspid annulus, at the time of a biatrial Cox-Maze-4 lesion, we should consider, given the European guidelines, to add a tricuspid annuloplasty for patients that have a tricuspid annular dimension of over 4 centimeters.
Because those patients will go on to develop
Late TR, and based on your comment of annular involvement, sometimes these patients could have late tricuspid regurgitation, which can add a layer of postoperative and perioperative morbidity to these patients.
It's important consideration, something many of us don't think about when we're going forward, and almost a little counterintuitive to us to fix something that doesn't appear to be broke. Put a ring on, because those patients are going to suffer from late tricuspid insufficiency, devastating to the patient.
I would only say is that atrial fibrillation in the majority of the patients that we address is part of the structural abnormality, the continuum of structural disease that we have in patients. And at the highest level, what we're doing is restoring structural normality. And that's whether it be valvular, or whether it be atrial, whether it be functional. And I think that's the whole purpose of what we're talking about, and the whole goal of being thorough in our approach to atrial fibrillation and patients that come to surgery.
Great point. Speaking of thorough, let me play the devil's advocate for a moment. Gentlemen, if you have a high degree of success with your maze, you're confident this patient's going to be in sinus rhythm, why do you have to deal with the left atrial appendage? And should you deal with it, and how?
Yeah, we think that taking care of the appendage is critical in every patient with atrial fibrillation in Norfolk.
You know, I think there's a lot we know and do not know about AFib. Even successful maze procedures, sometimes a year or two down the line, people develop AFib again for complex reasons that we don't always understand. And when you remove the atrial appendage and sew it off properly, at least you know that part of the cardiac anatomy is gone. And we know that is a very important nidus for clot formation in the heart when you have this arrhythmia. So this is something that structurally we can change. Everything else that we do with ablation lines and everything else, it's amazing that it works. And maybe that's why we call it the maze procedure, not necessarily the lesion pattern. But on the other hand, you know, it's a delayed gratification, because everything else we do in cardiac surgery, replace a valve, do a coronary bypass, the effect is immediate.
And you can see it.
And this takes time to mature and see whether or not you have an efficacious result in any individual patient. So I think from a structural point of view, the atrial appendage is critical.
I think Dr. Sheeman has hit upon the essence of this. I've taken the word cure out of my vocabulary with atrial fibrillation, supplanted success, because this is a continuum of disease, the degree of fibrosis of the atrium and so forth. And you may have success for 3 to 5 years, and the atrial fibrillation may recur, and we have to do something to deal with it again. But if you have eliminated the left atrial appendage, you've reduced your patient's stroke risk by at least 50%, probably 75% or more. How do we do that? What's the best way to deal with the appendage?
I think the primary responsibility of cardiac surgeons when you're approaching the maze procedure, to agree with my colleagues, is to address the left atrial appendage. It's the one thing we can do that our electrophysiology colleagues, at least for now, cannot do. So regardless of how you do it, whether it's resected and oversewn, whether it's approached from the epicardial surface, on pump or off, we're all talking about a complete Cox-Maze-4 lesion set, which is an on-pump operation as the primary modality and the preferred modality. It could also be approached endocardially, ablated and oversewn. I think, you know, we shouldn't force one of our colleagues that are getting into atrial fibrillation to one choice or the other, but it must be addressed, and it must be addressed thoroughly and homogeneously.
Also, you know, removal of the left atrial appendage if you're doing a full left-sided maze, actually makes it easier to do some of the lesions, particularly the connecting lesion between the left-sided isolation of the pulmonary veins and the atrial appendage. So if you realize how you can choreograph it into actually making the operation easier, and I think most of us realize that, excision and oversewing when you're doing a full left-sided lesion set is actually probably most efficacious and easiest to do.
And there's emerging data that the base of the left atrial appendage is an area that triggers Afib. So not only are we doing a structural repair, you're affecting a rhythm control methodology also.
Yeah, and Norfolk, we went through a journey of a lot of different techniques to address the appendage, and when I say address, I mean to close it. I think you just have to be comfortable with whatever you're using, that the base is tightly sewn and flush. There have been some advancements in some clips that we've tried, and frankly, I've been pretty happy with those so far. I don't know if they're going to be the end-all, be-all, but so forth, we've found them to be safe, and they do speed up the operation. So we will typically use a TE at the beginning of the case, and obviously it just goes without saying that to us at least is a very important step to make sure there's no clot in the appendage. If there is clot in the appendage, then we do address it differently. We go into a little bit of a no-touch technique, and we never put a clip or anything like that on that appendage. That gets taken off at the base and classically oversewn. If it doesn't have a clot, I think the clip is a very nice technique. You can open the appendage up and then make the ablation line, and then slide the clip on, and it's hemostatic, so it does speed things up quite considerably.
Gentlemen, thank you. Let me wrap up here by allowing everyone to have some final comments. We'll start with Dr. Sheeman, Dr. Philpott, and with Dr. Badwar. Final thoughts, final comments, Dr. Sheeman?
Well, the evolution of surgical ablation for atrial fibrillation has matured. We've got the technologies to make it easy and something that every cardiac surgeon should have in their armamentarium, and we owe it to our patients to provide, at the minimum, concomitant maze procedures on a routine basis at this point in time in surgical practice.
I think we've got two challenges which we've all hit on here. Number one, you got to do it. You got to get comfortable with it. You've got to get very, very practiced up on how to do this so that you're comfortable doing it. But then secondly, you got to get your results. You're not going to be able to know how you're doing. You're just basically flying blind without them. And once we can get our results, personally and as a society, that's when we're going to really be able to hone in on which lesions are absolutely critical or what do we need to add. There's a good possibility that we're going to need to add lesions instead of take some away in time. But we're not going to be able to have that information until we actually can find out how we're doing. So to me, and in Norfolk, the two major goals that we have in the upcoming year are that we improve our concomitant intervention rate up to about 80% for the entire practice, and that'll be a big challenge for us. But the second one is that we begin looking at success data at 1 year on a formal red light, green light platform, and I think that that is something that every center should have in the next 5 years at a minimum.
Whether you're a solo surgeon, whether you're a group practice, whether you're part of Centers for Atrial Fibrillation, of which all four of us are, I think it's incumbent upon every surgeon, as we've all touched upon, to address atrial fibrillation, not just because we say so or your electrophysiologist asks you to, but because it's the right thing to do for patients. Evidence is pointing in that direction that it's by adding a maze procedure or a surgical ablative procedure at the time of concomitant operations, when a patient comes to the OR in atrial fibrillation, you enhance potentially life and decrease long-term and short-term morbidity and potentially also readmissions. And as we focus on the quality collaborative we have in cardiac surgery, adding a surgical ablative procedure is one of those modalities that substantially enhance our ability to help patients, not in the short term, but in the long term. And so the final message I would say is that you have a patient with atrial fibrillation, go into the operating room, address it.
It's been said that the mark of a successful man is one who can reinvent himself. And surgeons have really led the way with direction provided by our database and motivation provided by our desire to provide excellence for our patients, we've reinvented ourselves several times. This is one more reinvention, one more technique we need to add to our toolbox. Gentlemen, I thank you for joining us today for this atrial fibrillation roundtable, and I thank you for watching.